Now, I think this points mostly, see, you have the afferent fiber. This afferent fibers mostly forms this cochlear nerve, and they are the one which carries the sensation from the cochlea towards the nuclei. But there are also some efferent fibers which are coming from the superior olivary complex through the olivo-cochlear bundle. And these efferent fibers, they modulate. They mainly supply the outer hair cells. The inner hair cells, they are mainly for the afferent, and I think the difference between the inner hair cells and outer hair cells will also be mentioned in the next slide, I believe. Now, the from the cochlea, you will have the, say, inner hair cells and outer hair cells. Then they will have these afferent fibers. These are, formed by the dendrites of the bipolar cells or the spiral ganglions situated in the Rosenthal canal in the osseous spiral lamina of the cochlea. The axons will form the cochlear nerve. Then they will travel. Then they will, relay to the dorsal and ventral nuclei at medulla. This is in the medulla oblongata. Okay. Now from there it will go to the superior olivary complex in the bones. Then from there again it will go to the nucleus of lateral lemniscus, then inferior colliculus, which is present in the midbrain, then medial geniculate body of the thalamus, and ultimately to the auditory cortex, that is in the superior temporal gyrus, the Brodmann's area 41. So that is how we are going to perceive, the hearing. Now, if there is any, say, defect, for example, we have to know at what level a child or a patient cannot hear. This is very important. So nowadays the science is very much advanced. With a cochlear implant, if the defect is at the level of the cochlea, say if the level of the cochlea, then you can do a cochlear implant surgery and a child can start hearing. Now imagine if there is no cochlea, then you cannot do a cochlear implant. Imagine if there is no labyrinth, you cannot do a cochlear implant. So in that case, we say, also if you think that there is no cochlear nerve, suppose there is no cochlear nerve, then also you can do any implant, because we require the spiral ganglion, we require a cavity, a cochlea, or at least the sensory neuroepithelium, for a child to hear. Now, if there is no cochlear nerve, then you can do a cochlear implant surgery. Even if you do a cochlear implant surgery, the child is not going to hear. So ultimately, what we do, we can do a brain stem implant. Nowadays, auditory brain stem implant is a reality. So we'll open up the cranial cavity. We'll go to the posterior cranial fossa. We'll try to find out the, cochlear nuclei, and there you can put the electrode, and that way a child can also hear. So this is the reality nowadays. So the anatomy of this, this inner ear, this structures, the brainstem, all these are important. And the one thing that you have to know is the higher up we go, the the clarity, or the the sound perception, it reduces. So if we have a cochlea but it is not functioning, if we have the ganglion cells, spiral ganglion cells, then those are a very good candidate for the cochlear implant surgeries. Now the inner hair cells and the outer hair cells, I think this mostly sums up, the inner hair cells, they are, say, around 3500 in numbers, and they are usually arranged in one row. They are flax shaped. Flax shape means almost like this. Cylindrical means like this. So they are flax shaped cells, and the nerve supply is primarily afferent, whereas the outer hair cells, the nerve supply is primarily efferent fibers. So the inner hair cells, they develop earlier, and the outer hair cells, they develop later. Function is transmission of the auditory stimuli, whereas the outer hair cell function is to modulate the function of the inner hair. They are more resistant to the drugs and ototoxic drugs and the sounds, whereas the outer hair cells are more vulnerable. Then, say, I think mostly we have discussed about the cochlea, because I think balance will be discussed by your Madam Baby Anand. So but in fact, one more point that I want to tell you is once say cochlea is there, then from the cochlea ultimately, as I have mentioned before, it will go through the cochlear nerve. Then you have the superior vestibular nerve, you have the inferior vestibular nerve, and you have the facial nerve. So these four nerves will be coming from the brainstem through the internal auditory meatus, and they all pass through the your vitreous part of temporal bone. Now through the internal auditory meatus. So internal auditory meatus, if you pass endoscope, then you can see that suppose this is the hole. This is the whole of the internal auditory meatus. Then you can divide it into different parts. See, you have the here this is the superior, this is the anterior, this is the posterior, this is the inferior. Now this bone is your falciform crest. This bone is your falciform crest. So this is the one which divides into a superior and an inferior compartment. Now in the inferior compartment you have only two structures. One is the cochlear nerve. So the cochlear nerve will be passing through this, and the other one is the inferior vestibular nerve. So inferior vestibular nerve will be passing through this. Okay, so remember, in the inferior cuts of the CT scan or in the inferior parts, you will see the cochlear nerve and you will see the inferior vestibular nerve. Then you have the superior. In the superior part, this is the Bill's bar. This bony partition is the Bill's bar. You can see here it's very small. So Bill's bar, this is a good anatomical landmark for surgery. So the facial nerve will lie anterior to that. This is the facial nerve. And the superior vestibular nerve will be lying here, that is posterior. So in the superior part you have the facial nerve in the anterior part. Then you have the superior vestibular nerve on the posterior part. You have the inferior vestibular nerve. Then you have the cochlear nerve. Okay, so these are the structures which passes through the internal auditory meatus, and this is often asked. Okay, now the remaining is you have to remember that it is around 3.4 millimeter in diameter and the length is around 8 millimeter. So all these points are important, you look up very nicely. Now coming to the little bit difference between the perilimb and the endolimb. The perilimb, as I have told you before, it is the fluid which is occupying between your bony labyrinth and your membranous labyrinth, and the endolimb is the one which is inside the membranous labyrinth. Now the perilimb resembles that of the extracellular fluid. So I think from the previous slides where we know that it communicates with the cochlear aqueduct. The cochlear aqueduct, it contains loose areolar tissues. Then this is cochlear aqueduct opens just below just near to the round window opening. And the cochlear aqueduct, it communicates with the subarachnoid space. So the CSF, cochlear aqueduct is one. Vestibular aqueduct, I told you before, vestibular aqueduct houses your endolymphatic sac, but the cochlear aqueduct doesn't house anything. It contains loose areolar tissues, and normally these are tight plugging is there, but the problem is sometimes the cochlear aqueduct also may be enlarged, and when the size of the cochlear aqueduct is more than 2 millimeter, then we may encounter perilimb gushers or CSF leak during the staphylotomy or during the say cochlear implant surgeries. So the size of the cochlear aqueduct is also important in understanding this anatomy is also very important. Now it is believed that this perilimb is formed from the filtrate of the say CSF or the CSF reaching to the via this cochlear aqueduct, or sometimes it is believed that it is a filtrate of the blood, that is capillaries of the spiral ligament. Then the composition is almost similar with that of the extracellular fluid, except that the protein is little bit higher, that is 200 to 400 milligram per deciliter, and glucose is around 85 milligram per deciliter. The sodium is usual, it is little bit higher in the extracellular fluid, that is around 140, and the potassium is usually lower, that is 10 millicurie per liter. Now the endolimb, it resembles the intracellular fluid, and this is secreted by the, you remember striatum vascularis I told you before. On top of that, you have to remember the dark cells of the utricle and superior semicircular canal near the ambulated ends. Now remember this. The absorption is via the endolymphatic sac, which is this is known as the longitudinal absorption, or via the striatum vascularis itself. This is a radial absorption. Now, any intracellular fluid or intracellular cells, say intracellular, say they will have this high potassium, that is 144. It's just similar to that, the potassium is higher here, and the sodium is around 5 milli equivalent. The protein is around 126 milligram per deciliter, and the glucose is around 10 to 40 milligram per deciliter. Now coming to the vascular supply, say there are two vertebral arteries. So there are two vertebral arteries, they join together to form the basilar artery. Now from the basilar artery, there is a branch known as the anterior inferior cerebellar artery. Remember, there is an anterior inferior cerebellar artery, and this anterior inferior, or ICA, usually we call it as ICA, anterior inferior cerebellar artery. They usually accompany the facial nerve. They usually, they're notorious for forming a loop around the facial nerve. Then the patients may have, hemispasm of the face. So this is important to us. Now, this anterior inferior cerebellar artery, it gives off a branch known as the labyrinthine artery, and this labyrinthine artery will have, again, will divide into two branches again. That is your common cochlear artery and the anterior vestibular artery. So this anterior vestibular artery will supply utricle, lateral, and superior semicircular canals. I think this is easy now. From the development, I told you, say they all develop from one fold: utricle, lateral, superior semicircular canal. Of course, the posterior semicircular canal is missing here. So this is the anterior vestibular artery. The common cochlear artery divides into vestibulocochlear artery and the main cochlear artery. So this main cochlear artery is the one who is supplying the 80% of the cochlea. And you have the vestibulocochlear artery, and from this you will have a cochlear branch which supplies around 20%. And as you know, the remaining, that is saccule and the posterior canal, which is not supplied by the anterior, is supplied by the posterior vestibular artery. Now I think this is pretty much easy, and this diagram makes it very easy also. This is taken out from your book, Dhingra. Now you have the venous drainage. So venous drainage is through the internal auditory vein, then the vein of the cochlear aqueduct, and the vein of the vestibular aqueduct. Okay. Now they ultimately drain into inferior petrosal sinus and the lateral sinus. I think by now you know all that this lateral sinus is also known as the sigmoid sinus, and this is lying, say it forms the posterior part of your mastoid. So clinical applications, say any distension caused by the endolymphatic sac, say due to the increase in endolymph secretions or decrease in endolymph absorptions, leading to the, say, episodic tinnitus, hearing loss, and vertigo, that is your Meniere's disease. Okay. Then you have the congenital anomalies, and out of that, this Mondini's dysplasia is the most common. And in the Mondini's dysplasia, the cochlea has got 2.5 turns, but here it will have only one basal turn, and the middle turn and the apical turn will be fused together. So this is 1.5 turns. And along with that, this Mondini dysplasia may be associated with the large vestibular aqueduct syndrome. So this is the most common form of your congenital anomaly in the cochlea. Meckel's aplasia is when the labyrinth is not formed at all. So then you have the cochlear aplasia, then cochlear hypoplasia. So many. Now this Mondini's dysplasia is also known as the IP2. We have the IP1, IP2, IP3. So I think those are not for you, but for the postgraduates. Then benign paroxysmal positional vertigo, I told you about the otoliths. Then from the say otoconal membrane, you have the otoconia, the degenerative changes or the trauma, some parts of it breaks, and then from the utricle it may go into the posterior semicircular canal, which is the most common. Then patient will have a episode of the vertigo. So whenever the patient doesn't move, it will be all right. But when the patient moves, this sediments falling will cause acute attack of the vertigo associated. Even this is a rotational vertigo, and they are usually very severe. Patients will be having nystagmus. Patients will be having, say, vomiting, nausea, then sweating, cold sweats, and they usually last for around 1 to 2 minutes like that. And then if they stay or they remain in that position, then there will be no vertigo. So this episodic, this is known as your benign paroxysmal positional vertigo. You have the labyrinthitis, which may be because of the viral or bacterial. So such patients will have acute attack of the vertigos, but they will last longer till the infections are controlled. Okay. Then you have the vestibular sonoma, any say tumor. It's a form of a tumor in the rising from the inferior vestibular nerve or superior vestibular nerves. So vestibular sonoma is very common. They also will have tinnitus, then your hearing loss. Vertigo is a little bit less here, as the tumor is a slow growing, and even the facial nerves, facial nerve sensation. You have the Silberger sign, where the patients will notice that whenever you touch the posterior canal wall, they will not feel any sensation. So the vestibular sonomas. Then you have the endolymphatic, say sex surgeries for the Meniere's disease, then cochlear implant surgeries, labyrinthectomy for any cochlear, say in case of the malignancies, or in case of the, say, intractable or uncontrolled Meniere's disease and all. So this is in brief about the clinical applications. Your book also mentions many, so you have to read your books also. So hopefully, I think in the next class, that will be for the physiology. We'll discuss in detail about the physiology again. In fact, it is difficult to include everything in the, about the anatomy of the inner ear in a single topic. It is for you to explore and try to learn. There are so many advancement in the science, in the medical science, especially concerning with the ENT. ENT, you can choose after you pass out your MBBS, you can choose ENT subject as for the post graduation. And there are so many, nowadays we have from the ENT, you can go for the anterior skull base surgery, then the lateral skull base surgeries, then you can go for the head and neck surgeries, mainly dealing with the cancers of the head and neck. Then you can go for plastic surgery. So there are lots of scope, but the only thing left is you have to study hard, and hope that you will do very good in the future. And thank you for the patient hearing.